Dear colleagues, I would like to thank the organizers for the invitation to be a part of this great event. Like all in Ukraine today, I would like to thank many hundreds of thousands of very brave men and women for protecting our beautiful country, its present and its future. If you think half an hour election is too much for the Gastrochisis, you should look at the program of this year's Fetal Medicine Congress in Valencia, where half the session on innovation in fetal therapy and surgery was devoted to Gastrochisis. It's hard to know, or it's hard to say whether it's all about evolving of fetal surgery or rather some unanswered questions have gathered and accumulated and must have been discussed. I declare no conflict of interest. This presentation is the result of long life cooperation between the Department of Fetal Medicine, obstetric clinics, and the Center of Neonatal Surgery of Congenital Malformations under the guidance of Professor Slepov. The clinical head of this department, Alexei Ponomarenko, the mildest and most intelligent doctor I know in my life, is now on the battlefield. If you ask me about an example of a perfect shortcut in a prenatal diagnostic, I would name Gastrochisis. Why it is so? The diagnosis is usually very easy, the ultrasound features are very specific, and prognosis is usually thought to be good. We have a very nice viral expression in OB-GYN ultrasound Ukrainian community, which was said by some unknown physician, the trainee of Professor Safonova. He said, ultrasound in gynecology is very easy. There is only one uterus and two ovaries, an exemplary shortcut as well. What do I mean under shortcut? It's the system-wide mode of thinking, the fast, stereotypic, unconscious, and there is actually nothing wrong with it. It saves us a lot of time and effort unless we use it for very complicated things. Is the diagnosis easy? In most cases, it is very easy. You see a bowel surrounded by fluid. Sometimes, of course, all bowel and fluid can be still in a sac, and a little bit of examination, you will find an umbilical cord attached to this sac, and the diagnosis will be, of course, not Gastrochisis, but omphalocele. Our pediatric surgeons don't think Gastrochisis is an easy entity. They have developed this very big classification. We will come to it further on in this lecture. World well-known Professor Opitz also doesn't think that Gastrochisis is an easy entity. He thinks that there is some nosologic, pathogenetic, phylogenetic, and causal uncertainty. These very well-respected researchers needed 3 full-scale articles to describe only the etiology of intestinal damage in Gastrochisis. Doesn't look like something very easy for me. International classification of diseases take Gastrochisis very easy, and it places it among not elsewhere classified malformations of musculoskeletal system. A shortcut. Gastrochisis belongs to major surgical emergencies in newborns. It means that if after delivery the baby doesn't get the specialized surgical help, it is actually doomed. A few words about classification. There are simple local abdominal wall defects like Gastrochisis or omphalocele, or abdominal wall defects can be a part of more complex multiple anomalies like midline disruption syndromes, pathology of control, OEIS complex, and others. The term Gastrochisis was presented by Italian scientists. It means the cleft of a stomach, and to my mind doesn't reflect the entity of this problem very well. But still, we have accustomed to it. It's hardly ever to change. We just should remember that defects of abdominal wall of other location and big defects of abdominal wall, you'd rather call abdominoschisis. And if one time at your work, like it happened to me at the very early stages of my trainee in OB-GYN ultrasound, you will see a huge conglomerate of abdominal organs attached to a fetus back, to fetus thorax. There is a pathology which is called thoracoschesis. So in case you meet it, you will know how to name it. So the main features in gastrochisis is, of course, eventuation of the abdominal organs through a paraumbilical full thickness defect of the anterior abdominal wall. The defect is almost always to the right, but there are exclusions. And eventuated organs are not covered by the amnioperinatal membrane. This is rather a rare malformation, but during the recent years, the trend was registered for the higher incidence. There is a lower incidence of chromosomal abnormalities, but you will definitely find in PubMed a few case reports, so you should be cautious. And also about syndromic and genetic pathology, cases were registered. It is well known to be associated with young maternal age, with smoking, soft recreational drugs, Hispanic maternal origin, anti-inflammatory non-steroidal drugs, and short interval between pregnancies. Of course, gastrochisis is usually a very early prenatal diagnosis, but there is a very nice case report in White Journal in 2012 about case which has been examined several times in the high level experienced tertiary hospital. There was a woman who presented with the history of fetal malformation. She was 39 years old. She has malformation of central nervous system and was multiple times examined by ultrasound and even by MRI. And there were no signs of gastrochisis, which has unfortunately presented at the birth. And the baby had also postnatally had a diagnosis of trisomy 18. Associated non-gastrointestinal tract malformations aren't very often, but there is very nice study which shows that in a certain specific group of cases, which are called by researchers hidden mortality cases, and includes spontaneous abortion, stillbirth, termination of pregnancy, and early neonatal death, the rate of associated malformation can be rather higher and extremely high. Associated gastrointestinal malformation are registered in about 20 to 25% of cases. Fetal growth restrictions we see up to 50 to half of cases. Half of the babies would have a birth weight less than 2.5 kilos. The level of antenatal death is actually rather high, as well as the rate of spontaneous premature birth. Is prognosis actually that good? Well, it depends upon the country you live in. Mortality varies significantly, starting from 1.4% to in high-income countries through 32% in middle-income countries and up to 90% in low-income countries. In a high-income country, the average length of inpatient stay for a baby with gastrochisis is about 35 days, and the upper limit, figure is about half a year. And average cost for treatment is about £20,000. And in the United States, these figures are even higher, and gastrochisis is considered to be one of the most expensive malformation there is to treat. Why is it so? What happens? The gastrointestinal tract needs time to recover its function, and often there are associated pathology of gastrointestinal tract, and this brings us to multiple bowel resections, rare laparotomies, adhesive disease. There is also a prolonged interval before start of enteral feeding. It means prolonged parental nutrition. It can be up to 1 year in certain cases. And of course, there is infectious complications like sepsis, acute liver failure, which might need liver transplantation. And in case of massive bowel resection, there is short bowel syndrome and intestinal failure syndrome. In the best cases, in uncomplicated gastrochisis with primarily closure, around 20% of babies will still have 3, 4, or more operations. If there is a staged repair in uncomplicated gastrochisis, it means 100% of babies, almost 100% will have 3, 4, or more operations. In cases with complicated gastrochisis, these figures are even more impressive. So the prognosis is good, but complicated, I would say. First reports on prenatal ultrasound diagnosis of gastrochisis date to 1978, and the first echograms looked like this. Luckily, the things have changed completely, I would say, and now we can see and evaluate this malformation very well. On the left-hand side, you see the second trimester gastrochisis. On the right-hand side, there is early third trimester gastrochisis. The second trimester gastrochisis looks very nice and bright, and maybe that's why the most of physicians have very good attitude towards it. But if they see such a video from a late third trimester patient with this hugely dilated stomach, which wants to escape from abdominal cavity and wants to get outside, their attitude might change a little bit. So what's going on there? The contact with amniotic fluid is very harmful for the eventuated organs, and they are also compressed in the lumen of abdominal wall defects. It all causes the impaired intestinal passage, impaired absorption, and hyperperistaltis. It causes increased volume of intestinal content, dilatation of exteriorized intestinal loops, poor blood supply to the intestine and intestinal wall, and parallel to this, because of contact with amniotic fluid, fibral layers are formed on the intestinal wall, and it's get thickened and rigid. It was shown in the experiment that the fibrin layers are formed only in contact with amniotic fluid, and there also was shown that there is a high rate of meconium staining of amniotic fluid in fetus with gastrochisis, and this associated is a worsening of postnatal outcomes. Here we see the stomach, dilated stomach, fully moved to the amniotic cavity from the abdomen, from the fetal abdomen. So here is translated classification from Ukrainian pediatric surgeons, and they defined, they have 6 criteria how they evaluate their case. They evaluate if there is absent or present and what kind of associated pathology there is, what's the defect location, does it have communication with abdominal cavity, is it open or closed gastrochisis, what's the amount of eventuated organs, what's the condition of eventuated organs, does the fetus has or neonate had growth restriction, and what's the amount of visceral abdominal disproportion. I propose you to go through this checklist, and I'll explain a little bit every this entity. So associated non-gastrointestinal pathology, well, it's rather easy, and we are very good at this diagnosis. We can help pediatric surgeons prenatally to get this information. We should be very careful when evaluating the limbs, because gastrochisis is known to be associated with arthrogryposis and other pathology of limbs and skeletal system. Facial clefts are also registered. Hydronephrosis often develops in later terms of pregnancy, and the cardiac congenital heart defects are described, but they are not very severe usually. In 2001, the team of pediatric surgeons have invented the term complex gastrochisis, and they described this as cases when there is present intestinal atresia or perforation or necrosis of volvulus. This complex or complicated is called also gastrochisis, is registered in about 11 to 17% of all gastrochisis cases, and it has very high mortality compared to simple uncomplicated cases. And of course, it has higher rate of complications and so on. Can we actually diagnose perforations or necrosis? Well, I doubt it, but in atresias we are doing not so badly. But the problem is that we have overfilled, overexpanded gastrointestinal tract, kind of stasis in gastrointestinal tract in fetuses with gastrochisis. This causes marked intestinal dilatation, gastric dilatation, the duodenal enlargement. We see often signs of peristaltis and contraperistaltis, which are typical, all signs are typical for intestinal atresias, but in gastrochisis cases would not lead us to definite diagnosis, unfortunately. These two stomachs are stomachs from fetuses with gastrochisis, and only one of them has intestinal atresia. Was there another ultrasound marker? Well, there was a polyhydramnios that would give us a hint that there is an intestinal atresia here. Another entity which is well known to the pediatric surgeons, but not that well to prenatal diagnostic specialists, it's closed gastrochisis, when there is a reduction and spontaneous closure of abdominal wall defect with varying degree of damage to the eviscerated intestine. And in very severe heart cases, there is a complete closure of the defect, and the eviscerated intestine is actually amputated, and it's also called vanishing gastrochisis. Here are the pictures, intraoperative pictures. On the left-hand side is usual appearance of gastrochisis. On the right-hand side, there is a case of closed gastrochisis. You can see very small intestinal conglomerate, and the skin is actually grown together with this intestine. Can we diagnose it? Yes, we can. If we see in the third trimester of pregnancy, instead of filled and dilated, evaporated intestine and empty abdomen, we see very small and compact intestine and very dilated intra-abdominal bowel loops, then we are almost sure that this is a closed gastrochisis. Can we do something with it? Can we intervene? Well, I hardly think so. This is their example from second trimester of pregnancy, the same fetus. This very small part of dilated, very mildly dilated, I would say, bowel is, I think, an early sign of this problem, which we see more obvious later in pregnancy. Amount and type of eventuated organs, of course, most often we will see intestine. Sometimes late in pregnancy we might see stomach as well, sometimes liver, but postnatally surgeons report that in about 40% of cases they see other organs such as bladder, uterus and ovaries, testicles, in boys, then even many other organs. So there might be some surprises if you ask the surgeon what they have seen in the operation. Eventuation of the liver significantly worsens the prognosis. And neonatal mortality can be as high as 57%, but with massive eventuation, we can come back to the question of whether it was actually a gastrochisis or abdominoschisis. Condition of enteric organs and intestinal wall is very important for the surgeons. It is actually rather reversible, but it can cause many problems. So we have, I have mentioned that there is formation of fibrin layers on the surface of intestinal wall. It is called peel. In severe cases, the conglomerate is very compact and is kind of glued together and sealed in a case. The intestine has dull appearance, has purple or cyanotic color. It is dilated, especially small intestines, very dilated, and there is a compaction and thickening of the wall. It has cartilage-like consistency. All this picture are the COTSI of our pediatric surgeons. Can we see it? Well, we can measure, of course, the intestinal diameter, but please be very careful. In different studies, people measure different things. Some of them would measure lumen of the intestinal wall. Some of them would measure the diameter, including the intestinal wall thickness. It may lead to different measurements and to different results. And here is the thin, unchanged intestinal wall. And here you can see the thickened hyperechogenic changed intestinal wall. Can we use the increased echogenicity alone? I don't think so. It's always a problem with gained, but together when you have thickened and intestinal wall with increased echogenicity, that's the clue to the diagnosis of a changed intestinal wall. Fetal growth restriction, well, what can be complicated about it? Well, it's non-classical in gastrochisis, not of placental origin, and its origin is not fully understood. Perhaps we don't know completely about the role of gastrointestinal tract in intrauterine fetal growth. It often has no signs of fetal compromise or changes in maternal uterine arteries, but still there is a risk of stillbirth. Biometry might be challenging, especially in third trimester, because there is a displacement of anatomical landmarks, and reduced amount of amniotic fluid is also very characteristic for gastrochisis. Hedlock's formula is the most accurate for the fetal weight evaluation, and the part of this situation is also abdominal cavity hypoplasia. Visceral abdominal disproportion is a clinical and anatomical situation when the volume of enterated organs significantly exceeds the capacity of abdominal cavity, which makes impossible their immediate reposition. It can be evaluated with different methods during the operation, but if the surgeon press too high when they insist on primarily closure, they can get abdominal compartment syndrome, which is a consequence of increased pressure in abdominal cavity and can lead to impaired blood flow, hyperperfusion, hypoxia, and organs failure. Can we assess it somehow prenatally? Well, our surgeons propose that somehow to try and do it. And we have together developed this method of prenatal assessment of visceral abdominal disproportion. So we measure three diameters of abdominal cavity under the level of liver, and we measure three diameters of the eventuated intestine. In third trimester of pregnancy, it's very challenging, but I think it can be compared with the measurement of the lung in congenital diaphragmatic hernia, so it's kind of feasible. So we calculate the volume of abdominal cavity and of eventuated conglomerate and divide the volume of the cavity to the volume of eventuated organs and get an index. And if it more than one, this proportion is considered to be absent. Between 0.5 to 0.9, there is a moderate disproportion. And when it's less than 0.5, the disproportion is considered to be severe. What have we noticed? That the amount of cases with absent disproportion in second trimester is higher than in the third. So the process evolves, and extreme values of this index coincides with extreme situation, like extremely low index was calculated when the liver eventuation was present, and extremely high index was registered in cases of closed gastrochisis. Which outcomes we have seen in different groups? Well, in cases with prenatally evaluated severe visceral abdominal disproportion, we have noted a much higher level of stomach eventuation, which is logic. We have also seen postnatally, our surgeons have seen a much higher rate of severe changes of eventuated organs. The rate of complicated gastrochisis was higher, but didn't reach the statistical significance. There was, of course, the higher rate of stage reduction, and the mortality rate was higher in this group, but it also didn't reach statistical significance. So what do we do with all the information gathered? We put it all in diagnosis, and our diagnosis usually take some place and bring all the possible necessary information about the patient to the pediatric surgeon. Usually the surgeon would come to our department to see the patient, the fetus for themselves, but if the lady goes to other people, they can use this information as well. Well, what about information? Okay, we have it. Can we somehow create a prognosis for the future outcomes? It's very complicated and very important and very researched field. There is a certain entity of ultrasound science which are studied and they are combined. They study their significance for different postnatal outcomes. And in this classic meta-analysis of Antonio from 2015, the authors have meticulously gathered all the most important ultrasound signs like intra-abdominal bowel dilatation, extra-abdominal bowel dilatation, gastric dilatation, bowel wall thickening, polyhydramnios, smallness for gestational age, and tried it for these outcomes. And the only things I have found is that intra-abdominal bowel dilatation associated with bowel atresia, and as well polyhydramnios has also associated with bowel atresia, and the gastric dilatation was associated with higher levels of neonatal death. That's all there is. I think in the nearest future, we might see more complicated prognostic models like we have in congenital diaphragmatic hernia. I think somebody is studying it right now. If you're all welcome to do this research as well. What about our data? it was this our local cohort study. We have studied only the incidence of the mentioned ultrasound signs in groups with negative and positive postnatal outcome. And we have found that in cases of severe visceral abdominal disproportion was registered higher in a cohort with negative outcome, as well as gastromegaly, as well as changes of intestinal wall, small phagocytasis, status, and polycythemia. So all the same as in the results of the above mentioned meta-analysis. Well, the most actual field for research nowadays is a complex gastrochisis and ultrasound prognostication of the complex gastrochisis. If I understand correctly, the fetuses which are supposed to have a complex gastrochisis are considered to be a choice for prenatal interventions. There are a lot of studies, and the recent meta-analysis from 2022 showed that both intra-abdominal and extra-abdominal bowel dilatation and gastric dilatation and polycythemias were associated with the presence of complex gastrochisis postnatally. And in this study and many other cases, the researchers have noted that the earlier change their rise, the more specific they are for the prediction of complex gastrochisis. For instance, intra-abdominal bowel dilatation in second trimester is more powerful for prediction of complex gastrochisis. So are there any interventions? There are some prenatal amnio infusion and amnio exchange was a very nice idea. If the amniotic fluid is aggressive, why not change it? But it was shown to be not effective. Now there is a new wave with infusion of stem cells in amniotic cavity, and fetal surgery will be developed into directions, with the direction of trying to with the attempt of reposition of eviscerated organs, or their coverage to take them from the harmful influence of amniotic fluid. There is such an intervention as early delivery, since the amniotic fluid is bad, and let's take the baby out. Well, there are two actually variants: late preterm delivery or early preterm delivery. For the late preterm, the benefit was not proven, and early preterm delivery has turned out to be actually harmful. But of course, in certain clinical situations, people are using it. C-section, the benefit has not been proven, but if you see the results of the studies published, you will see that there is a huge difference in approaches to this question. And it seems that the more to the south the country is, the more is the rate of C-section, and northern people are choosing vaginal delivery much more often. What can we do with the pregnancy with all this information we have from prenatal exam? Well, there are many discussions in the field. Whether if we get very good at diagnosing of complex gastrochisis, will it become an indication for termination of pregnancy? Then there is a question that the associated pathology is often non-lethal, but in this case we still have multiple anomalies. Will this be an indication for termination? Also, the questions of prenatal monitoring is not quite regulated, and there are various variants in various clinics in various countries, but it has been shown that a close prenatal monitoring can reduce the rate of intrauterine fetal death by half. Well, delivery planning, of course, depends on many things like results of ultrasound exams, country where you live, and how your obstetricians and surgeons see this situation. What I would like you to remember from this presentation, that gastrochisis is a complete anomaly, a complicated anomaly, and can change significantly during the pregnancy. So you have to make your evaluation and your diagnosis complicated as well. A good prognosis can result in not so good outcome. Consultation should be carried out in a specialized center which collaborates with pediatric surgeons. Severity and prognosis evaluation is important, but rather complicated, and there is a huge field for research. I would like to mention one very important thing about shortcuts. If you could, please, right now or at home or on Monday at your work, please turn around and look around yourself. Look at everything you see every day, everything you like, your family, your children, your parents, your favorite house, your favorite gardens, your favorite working place, your colleagues, your patients, all that surrounds you, all which gives you joy, all which is part of your life. Well, in a shortcut world, in our news world, these wonderful, great things are often called territories. And well, they are not. Thank you very much for your attention, and I will be very glad to answer any questions. Thank you very much.
Good evening, dear participants. We are moving fast for the end of this for this conference. It's very dark already in Kiev, and the last lecture will be done by Dr. Kaczynski from Medical University in Warsaw, our close neighbor, and it will be devoted to congenital diaphragmatic hernia. Please.